Welcome to these PCR webinars on bioresorbable scaffolds. Are we ready to go back to the future? Are we ready to endorse again this technology in our clinical practice? My name is Emanuele Barbato. I'm from Rome in Italy. And on this topic, we'll debate here with me Andreas Baumbach from London, United Kingdom, in the studio, and Manel Sabaté from Barcelona in Spain, from his office. Hi, Manel. Hi, Andreas.
Hello.
Good afternoon.
This is a debate, so you can go either with Andreas, who is contra, or with Manel, who is pro this topic. So thumbs up for one or the other, if you prefer. But this is an interactive debate, so don't miss the opportunity to let us know your opinion through your chat box. Just let us know your questions and comments. But before we kick off, I'd like to pose the first question to you. Do bioresorbable scaffolds have a place in clinical practice? Please take a moment to answer these questions. And while you're doing that, let me share with you the learning objectives of our debate. Join us if you want to understand the evolution of bioresorbable scaffold technology, to debate on pros and cons of bioresorbable scaffolds, and to discuss practical case example on the use of this device today. In the meantime, surprise, surprise, we've got here the answer to our question. So stay strong. Do bioresorbable scaffolds have a place in clinical practice? 100%. I'd like to see how many voted for this 100%. Say yes. That's amazing. Okay. That's the way we start.
That's a great start.
That's a great start. So hard time for you, Andreas. Why don't you just tell us why you're against this technology? What went wrong? Why didn't we learn enough?
Thank you very much. So, but that's a great start. If 100% of you...
well, 95%. Now
95.
It's getting...
That sounds like you know, an election result somewhere further east. So I take a role here, and my role is to convince you that absorbable scaffolds play absolutely no role in clinical practice, as completely opposite to what you think. And I give you 5 really good arguments why that is so. First, we actually really don't need it. There is no unmet clinical need. We have results, and that's just 2 examples out of many, with modern stents where we get target lesion failure, TLF rates of 10 to 15% at 5 years in all-comer populations. How will you possibly better that? Second, why should we use inferior technology when it has taken years, decades, to develop modern drug-eluting stents that are now thin, ultra-thin, like on the right-hand side with 60-micron struts, with very high radial force, with drugs on them, with a size matrix that really can optimize the deployment towards the lesion length and width and the size of the artery. These metal stents, the drug-eluting stents, they are expandable. The 3.5 goes up to 5.75, and the 2.0 goes up to 3.75. We can really choose and optimize the size of the stent with these modern drug-eluting stents. And then, of course, we know they have sometimes absorbable, sometimes no. It's just the polymer and the drug in there, and they endothelialize very fast. And we have multiple products now where we can actually minimize the dual antiplatelet treatment needed after deployment, particularly in high bleeding risk patients. Compare that to scaffolds. The struts were thick, they have low radial force, they're undilatable because they break, they're invisible, there is no 2-stent strategy with them, they've got limited shelf life, and a need for prolonged dual antiplatelet treatment. Third, which lesions do you want to treat? We'll discuss that later, but one thing is clear, it's not this one, It was a heavily calcified aneurysmatic that needed lithotripsy. And we can do this easily with the modern stents, but not with a scaffold. Not this one either. It's a left main, it's way too big. We can't expand one element and certainly can't use two stents, but we can with metal stents. And lastly, this one either not, because it's an LAD bifurcation 111. What you need is a DK crush, and we can't do that with a scaffold, but we can achieve really good results with metal. Now, this one is good, a short, non-calcified LAD, and that can be treated, of course, with any product that we have out there. But how many type A lesions do you actually treat in your practice? 4, so far at least, it was way too difficult. Look at this paper from Abi Zaid, that was for the Absorb, and that's just these 8 steps to size a scaffold, let alone the PSP or PPP. That's actually Manel Sabaté's paper here that explains us how to get to a good result. It's way too difficult. And 5, we really tried, didn't we? And we failed. You know, these were the promises: golden tubes, vascular restoration, less angina at some stage. We had more than 125,000 patients treated with the absorbable scaffold, 13,000 patients studied. We did registries. We implanted 1,000 patients in the UK and looked at their results. And there was a new paradigm out there: provide temporary vessel support and then allow physiology to recover and evolve naturally. And we all believed in it. And do you remember what happened next? This happened. On the expectation levels, they got bigger and bigger. But as the results came in, the gap between reality and expectations and the satisfaction became unacceptable. This is from Davide Capodano. And of course, enthusiasm went away and the technology disappeared. Now it seems it's coming back. And we do get long-term results, but still, I think this stands. No clinical trial has ever shown superiority of absorbable scaffolds over standard therapy. And I put one slide in yesterday because that's the first good news in a long time in the New England Journal yesterday, where actually BVS was better than standard therapy, albeit below the knee. So my 5 arguments stand. There is no unmet need. It's inferior technology. We have limited suitable lesions. The implantation is way too difficult. And we should learn from failure with BVS and leave them alone. And now, do we really want to go back to the future?
Great points, Andreas. I need to correct myself. The poll was on the way. Actually, we got a more split audience. This is an information also for Manel, who comes next. 55% are believers among our colleagues. 45% are non-believers. So there is still work to be done. Perspective is sobering from Andreas, but he showed us a tiny light at the end of the tunnel. What's your take here, and why are you pro this technology?
Yeah, thank you, Manuela. Thank you, Andreas. Great arguments. And of course, this relates to the past. We'll see what's going to happen in the future. I'm happy to take the pros in this debate. If we start again with the promise of the so-called vascular restoration therapy, is that you can implant a device that can disappear over time, and then you leave nothing behind. That was the great promise that by the use of the absorbable scaffold, the Absorb, that all of us have in our minds. Also, we wanted to seal unstable plaques by healing the potential of the rupture of the plaque. And finally, and this was the major promise from this technology, was that with these devices, we could restore the vascular vasomotion. the coronary vasomotion. These were the most important assets for this technology to be accomplished. So starting with the disappearance of the device, we have good examples of how absorb disappear over time. You can see here in this slide that at 5 years time, this is the so-called golden tube. Nothing there, nothing behind. But we have to admit that you can see here in the slide as well, that at 2 years, we still can see remnants of the scaffold inside the lumen. So this, they absorb, disappear, but disappear at long-term follow-up. What about another type of bioresorbable scaffold, the magnesium-based bioresorbable scaffold? In the MAX-STEMI trial, we randomized MAGMARIS, the first or the previous generation of the magnesium-based bioresorbable scaffold, against sirolimus eluting STEMI or Cyro in STEMI patients. At 1 year follow-up, just 1 year, the struts disappear in almost 1/3 of the cases, or were integrated inside the lumen in a 1/4% or 25% of the cases, or just showed protruding struts inside the lumen. And this was comparable to that of the Orsairo. And a few instances of protruding and malapose stents were observed in both instances. But just, I think, to confirm the idea that in this case, at 1 year follow-up, the magnesium-based bioresorbable scaffold disappeared. In the most contemporary generation of the MAGMARIS, the new DREAMS-3, the third generation of the magnesium-based bioresorbable scaffold, again, at 12-month follow-up, it disappears. And apart from that, it improves the outcomes in terms of reduction in late lumen loss as compared to the previous generation of the magnesium-based scaffold. Regarding sealing plaques, I think this is a nice paper from Salvatore Brugaletta showing how can the scaffold seal the plaque. And this was a nice OCT image of a scaffold implanted on top of the plaque. And then at follow-up, how by disappearing the scaffold, the thickness of the cap separating the lumen from the plaque increase, making this plaque more or less prone to rupture, more consistent, more resistant to rupture. The final concept of the restoration therapy was the ability to restore coronary vasomotion. This is a good example of implantation of the bioresorbable scaffold in this mid-segment of the LAD. This was an absorb. And at 3 years follow-up, you can see this image. This is baseline image that then after nitroglycerin, how this coronary or stented or scaffolded segment could be dilated by the use of nitrates. So in this area, you can restore the capacity of vasodilation of the vessel. You get the comparison between pre-nitroglycerin and post-nitroglycerin in a prior stented segment. But we have to admit that the ABSORB2 was one of the pivotal trials comparing ABSORB and Xience, could not be able to demonstrate any difference in restoring the vasomotion at 3 years' time. And this could be probably related to the fact that at 3 years' time, still some scaffold, some remnants of the scaffold were present in the vessel wall, preventing from any further vasoconstriction or vasodilation of this segmented area. But on the contrary, by the use of a magnesium-based bioresorbable scaffold, this technology could be able to demonstrate that the vasomotor response is restored, and you can, at 1 year follow-up, restore the capacity of vasodilate and the capacity of vasoconstrict after infusion of acetylcholine or nitroglycerin. And the primary endpoint of the study was met, showing an increase in the percentage of segment with a proper vasodilatation after nitroglycerin and a continuous or an important increase in vasodilatory response after nitroglycerin. So the three parameters of the promise has been accomplished by the use of coronary scaffolds. But I have to admit, and I fully agree with Andreas, that the performance of the prior generation of the resorbable scaffold absorbed was not the same as a DES, and the safety, of course, was not the same either as a DES. You have to remember that the main cause of withdrawing the use of absorb was the concern regarding thrombogenicity. Okay, so this is the minimal requirements that any scaffold or new device should achieve to have a good performance, a good safety, a good efficacy, and long-term benefit as compared to drug-eluting stents. What about the new magnesium-based bioresorbable scaffold? With the new iteration, now the thickness of the strut is much smaller, 99 less than 100 microns. The scaffolding time, which was the main cause for having restenosis by the use of this magnesium-based scaffold, has now been prolonged over time, keeping the vessel more scaffolded during this period and keeping the same resorption period of 12 months. With that, the properties of the new device resembles more the properties of an Orsiro of a metallic stent. You see here the radial force of the new DREAMS 3G, or now the so-called FreeSolve scaffold, is as good as or the same as Orsiro, and also the trackability force is less than that needed for the Magmaris, and the crossing profile also decreased as compared to the previous generation bioresorbable scaffold. So the mechanical properties are more and more close to that of the drug-eluting stent. Safety, I think, for the magnesium-based bioresorbable scaffolds are very good. We don't have any safety concerns. You can see here a bench study showing that the platelet adhesion of the magnesium-based as compared to absorb, or even as compared to metallic stent, is very, very, very low. And in clinical practice, this has been demonstrated. And for the first time, I can show you to you what is the result at 5 years follow-up of the MAXTEMI trial. You know, because it has been already reported, that 12 months there was an increase in target lesion revascularization due to the restenosis induced by this short period of scaffolding time that now has been solved. But beyond that period, there's no other event in the Magmaris cohort. Regarding device thrombosis, not a single thrombosis in this 5-year period has been observed in the Magmaris, and no cardiac death has been observed during this 5 years period. So I think that the safety concerns has been resolved by the use of this new technology on the magnesium-based bioresorbable scaffold. And now we have new iteration, the new technology that increase or resolve the issue of the early collapse of the magnesium Magmaris stent, and now the late lumen loss has been decreased by this new technical improvement by the use of in this magnesium-based bioresorbable scaffold. Now we'll see in the coming trial, the BIOMAG-II, that will involve more than 1,500 patients, in total of 1,700 patients, in a global trial, randomized trial, comparing to a metallic stent, and with a clinical heart endpoint, target lesion failure. We'll see that probably this device will compare well with the conventional standard drug-eluting stent. So regarding minimal requirements needed for this device, I can tell you that the performance now with the new technology is as good as a DES. The safety is as good as, or even maybe even safer than the current generation DES. But we'll see in the near future, with with the coming trial, the BIOMAG-II trial, and some others that will come in the near future, how will be the long-term benefit as compared to the drug-eluting stent. So my conclusion is that the promise of bioresorbable scaffold has become real. The device is able to disappear at 1 year for the magnesium-based bioresorbable scaffold, and this allows the restoration of vascular reactivity. We have several examples in BioSolve, MaxSTEM, etc. The performance of the previous generation BRS was truly inferior to that of current generation, but now with the new magnesium base may mimic the performance of a drug-eluting stent with an increased radial force, prolonging scaffolding time, reducing the strike thickness, etc., without having no concerns regarding safety. But however, further randomized trial will shed light on long-term benefit of this technology compared to drug-eluting stents. Thank you. I pass now to Emmanuel.
Well taken, Manel. I took some notes from your slides. You listed 3 key points that should make bioresorbable scaffolds preferable to contemporary drug-eluting stents. So disappearance of the device, restoration of vasomotor function, potential of plaque sealing. Now, the question goes back to our colleagues. Do you think these 3 key features are relevant to your patient? And if so, in which patient, in which lesions? Let us have your feedback in the chat. Now, Andreas, why do you think metallic BRS, magnesium-based BRS, have better chance than the previous generation plastic BRS that we used to practice with?
So I'd expand that question and say, why can we have new generations of scaffolds? Because all I've said in my contra talk was really relating to the first generation of the Absorb. And there we had a thick strut scaffold with low radial strength and a practice that expanded way too quickly into lesions that shouldn't have been treated in the first place. But for that, we have large number of data, and the stent thrombosis rate or scaffold thrombosis rate around 3% is just simply not acceptable in the current environment. So let's put that aside. But there is a second generation, third generation of devices coming. There is also some newer, thinner strut plastic scaffolds coming. But the real new kid on the block, which isn't new at all, it has been around for a very long time, but with new data and new technology now coming along is the magnesium-based stent, which has been developed now, which has developed into a really different proposal. I had one in my hand last week at ACI in London. It looks like a metal stent, it feels like a metal stent, it is elastic like a metal stent, and what Manel has shown us in terms of data, it is a versatile stent that behaves like a metal stent, and the safety data look good. So here we have something that is that we really need to have an eye on, and we need to see where this is going. But this looks different from what we had before.
Manel, the stent looks different from what we had before. So the obvious question to you is, can we implant these devices the same way we would with current drug-eluting stents? I recall the time we used to have the polylactic acid VRS. There was the so-called PSP protocol. So lots of lesion preparation. The setup should have been optimal, good backup, good wire, in order to make sure that this device could be delivered and optimally implanted. Are there special precautions that we need to take also with this generation BRS, I mean the magnesium-based?
Yes, I think that we have to keep the same parameter, the same technique to implant the scaffold, the stent, but you have to keep the same technique for every single device, not just for the magnesium base, but also for the stent, a drug-eluting stent. We have to prepare the lesion, You have to size properly the stent. You have to post-dilate. There is something we have to do every day that sometimes you forget it when you are using a drug-eluting stent because they are always okay. Then you forget to prepare the lesion, and then you leave an expanded the stent. So for BRS, for sure, this is truly important, and you have to do a good, proper preparation of the lesion, a good sizing of the device, and a good post-dilatation of the stent. So, but you have to do a proper job always, not just for this this technology.
So the BRS platform has evolved such that now we have more stent lengths, sizes, even the strut thickness have gone down. Does it mean that we are ready with this magnesium-based BRS to treat all lesions, all patients? I just want to share with you some comments from our colleagues where they would implant these stents. One colleague said young patient, another one long lesion. What is your guess?
I think we need to be led by caution here. We've made the mistake once as a community that we expanded the technology too quickly into areas where it just wasn't suitable. This new technology looks as if it has the potential to be used in a broader spectrum, I agree. But there are quite obvious limits in that we want to treat patients and arteries that can heal. i.e., it doesn't make any sense to use this technology in heavily calcified arteries that are beyond repair and just need a metal scaffold in order to stay open. So I would restrict the use, particularly at the beginning as we are learning and as we are waiting for the long-term results to come in from trials. I would restrict it to exactly those arteries where we actually can achieve a good result and have the hope that the artery will completely heal so that the patient can actually use the vasomotor function in the long run.
I can tell you the chat is really warming up here. One question to you, it's high time, Manel. Can we use this device in acute coronary syndrome?
Mm-hmm. Yes, I think that's the proper time to ask me this question. Yes, I fully agree on Andrea's comment. We have to implant the device in a patient that have the opportunity to heal the lesion and to have the opportunity to live enough to have benefit from this vascular restoration therapy. And of course, don't go to calcified lesion. And then answering the question, yes, I think the acute coronary syndrome could be the potential of this device. And with that, I can show you an example of that with a clinical case. May I have the slide? Just
coming up. Yeah, can you, yes.
Yes, okay. So this is a young patient, young male patient, 56 years old, hypertensive, smoker, nothing special like the current population, having an ST segment elevation myocardial infarction. This was in 2018, and this was his ECG with the ST elevation in the interior leads on the ECG. So the primary PCI was performed, and you can see here the coronary angiography showing a subtotal occlusion of the LAD, the mid-segment of the LAD. And then, of course, we opened the vessel, we crossed with the wire, performed thrombectomy. We did balloon angioplasty with a 2.5 and 3.5 balloon after getting rid of all the thrombus from the vessel. And then, in this case, the patient was included in the MAXTEMI, and we implant the McMurray, a 3.520, as you can see here in the middle. We post-dilate this device with a 4.0 balloon. So this device can be post-dilated with a 4.0 balloon. And then this was the final result. with a good TIMI-3 flow, a good final angiographic result. And then the patient is fine, and 1 year follow-up. This was in 2019, and this is the angiography at baseline. And then after nitroglycerin, because I remember the MAXTEMI was supposed to demonstrate a benefit in restoring the vascularity, the vascular therapy. And then you can see how with nitroglycerin, the vessel dilated, even in the stented segment. So we recovered the function of this vessel and the function of this patient. And you can see the OCT assessment. You can you show? Yes, it's coming.
Yeah.
And you can see here the optical coherence tomography study in this vessel 1 year later. You will see here at 10, here, the marker of the distal marker, the platinum marker. Then there's nothing there, just maybe some few protrusions here and there, but nothing else. In the indistinguishable struts there all over the stented segment. And we'll see next here 3 again, the marker of the proximal marker of the device. So it's a perfectly healed plaque rupture in the past with restoring of the vascular, of the coronary vasomotion of this patient. So I think this is a good example, a good setting of the patients that may merit being treated with this technology.
Thank you very much, Manel. Actually, this is indeed the perfect setting. You know, STEMI patients are usually younger than non-ST elevation MI patients. And those are the patients where most of the vasoconstriction goes on in the acute setting. So the risk of undersizing or underexpanding the stent is there. And having a device that will be forgiving in a way, even if I saw here that you post-dilated anyhow with a 4 millimeter balloon, this 3.5 magnesium-based BRS, it is in a way reassuring the fact that this platform will disappear. Now there is a relevant question on this topic from one of our colleagues. I don't know who wants to take it, whether Andreas or Manel. Are overexpansion capability of magnesium-based BRS better than PLLA-based BRS? Who wants to take this one?
I think, Manel, that's you've got the practical experience, but from the data, it already looks as if there is a huge difference, and the magnesium is more pliable. It's more dilatable than what we have seen with the Absorb. Is that correct?
Yeah.
Excellent. Another relevant question, but I think in a way I saw your data, Manel, on the MAXTEMI trial 5 years follow-up. One of our colleagues is concerned about restenosis. In particular, his concern is that BRS is not the best option for restenosis. Why? Because it doesn't prevent new intimal proliferation at short term, and constrictive remodeling plays a role because of this forced collapse. Is it really an issue, Manel?
This was the issue, and that's why there has been a lot of improvements in this context. Because we really investigate for the causes of this increased rate of restenosis, and mainly was due to the early collapse of the scaffold, not because of increase in neointimal perforation, rather more the early collapse. Now, with prolonging the scaffolding time, this has been reduced, and you can see the data from Biomax showing the late lumen loss has been really mimicking that of a conventional stent within the range of 0.2. So this has been really a huge effort from the company in this case to really be able to prolong this scaffolding time and to improve the restenosis induced by this early collapse.
Moving from efficacy to safety, it was reassuring again to see this data from Manel concerning the very single digit, I would say even below 1% scaffold thrombosis rate, which is just what we would expect from any drug-eluting stent. But nowadays, we are discussing more and more, or withdrawing earlier the dual antiplatelet therapy and putting those patients under single antiplatelet therapy as soon as possible, because we are giving enough importance also on the bleeding risk side. Any thought, Andreas, on this point?
Well, but just to clarify and maybe repeat, I think we're now looking, if we talk about the magnesium platform, which now accumulates large data, with the Magmaris, they had an 0.6% stent thrombosis rate at 4 years, and 5 years is coming, which is amazing. And the newest platform with 116 patients, they don't have any stent thrombosis in there. So this is, again, different and very promising. I think to answer the question about the dual antiplatelet treatment, we can actually go back to our task force paper and recommendations at the time of Absorb, where we said it's intuitively the right thing to give dual antiplatelet treatment at least as long as it takes for the device to disappear completely. And for Absorb, that was 3 years, and we know that there was a difference in adverse events if patients only had dual antiplatelet for 12 months. So at the end, we all gave 3 years. And again, for the magnesium base, this would be 12 months, maybe less because it really disappears fairly quickly. But I think we have to be careful again, and I think we have to respect the biology, and we have to then do the clinical trials.
Speaking of clinical trials, Manel, there is a relevant question that in a way pertains also to the right place for this device, where to really position this device in clinical practice. And one of our colleagues is asking whether there is any ongoing or there is in the pipeline trial involving elderly patients using scaffold. It's one of the hot topics nowadays.
As far as I know, not with this technology now, maybe in the future. The next trial will be the BIOMAG-II, which is going to be quite open but restrict to the lesions that can be treated, not again, as Andreas said, calcified lesions, etc. So I think that is going to be more restricted. It's not going to be not at all comers, but at least lesions that can be treated with a proper technique. And that, but for the elderly, still we don't have any trial coming. But surely, because of the APT and all this stuff, I think this is a trial to do. And also for the APT itself, I think it may require a specific trial, dedicated trial by the use of magnesium base. But if it's true, and I believe it's true, that is so safe, I think that also we can go for shortening the APT as in the DS. But it has to be proven in the trials. Huh?
I have a technical question. Again, back to you, Manel. Is IVUS, because in your example you showed OCT, but one of the colleagues is asking whether IVUS is also okay to assess the scaffold with magnesium, for example. Yeah,
in general, the difference between IVUS and OCT is clear, the resolution of the one technique versus the other, but this metallic is like a metallic stent. Then IVUS is also good for this device, and which is not the case for the BBS. BBS was barely visible by IVUS, just on OCT, but with this device you can use IVUS as well. Yeah.
Excellent point. Another colleague again on DAPT strategy in a new generation BRS. I think you properly addressed these questions. For the time being, let's stick to the duration of resorption of the device, and in the future.
Let's play it safe. But I think as I said, respect biology. It makes sense to stick to these rules at present.
Another question, good question, I must say. What do you think about any leftover material after degradation, like calcium phosphate? Magmaris has shown to leave behind something like a skeleton. Is it a concern, perhaps, for you, Manel?
Yeah, this was my concern as well. When I remember they in the past they explained how the magnesium absorb or reabsorb, And I was thinking, oh, Jesus, we're going to calcify the vessels. But you have seen, and the results of MaxTemi are the proof of concept that you may restore the vasomotion of this segment. So the vessel is not calcified at all. And you have seen also the OCT assessment that there's no calcium there preventing from vasodilation. So this is a conceptual thing, but it's not impairing any vascular reactivity of the coronary.
We have time just for a last question, hopefully with a short answer. Because it's an important one. Can the side cell of the magnesium-based BRS be recrossed and opened with kissing balloon inflation to the side branch as it is with metallic stent? You know, they are warming up now.
I would say yes, but I think what I can say is for the protocol for the upcoming trial, we're allowed side branches, but only vessels where we wouldn't expect to put 2 stents in.
Great answer. Wisdom, always in what we do every day. Can we have back the slide? Because I'm curious to pose again the same question to our colleagues. Again, let's do another try. Do bioresorbable scaffolds have a place in your clinical practice? After have you heard this debate, honest debate, I must say, from Andreas and Manel? Please again take a moment to answer this question. This time I won't make the mistake to read the results quickly because the system needs time to calculate the percentages here. While you are responding, I'm just sharing with you some conclusive remarks, and stay tuned because I'll share with you the results of the poll at the end. So new generation BRS is on the way, especially with magnesium-based platform that resembles closely contemporary drug-eluting stents from a technical point of view. Early clinical results are good, no question, showing good safety and efficacy in different clinical and angiographic settings. And ongoing clinical trials will answer the very last questions we are waiting for, which is whether the future is back and BRS can play a role in our clinical practice. And now we are ready for the results of the poll. You know, I actually disattended your initial thought. Now it's still moving. But I can tell you that we moved from 55 against 45, and now we have 94% pro BRS and 6% contra. So very well done. I have to say, the winner is Manel.
I lost.
Since it was a debate, and Andreas here in the studio lost. Now, out of a joke, I think I would like to thank really heartwarmly the 2 opponents, Andreas and Manel, to share their experience, their good arguments, and their wisdom. I think this is the most important point. Thank you very much for the technical crew to make this possible, to the sponsor who provided his unrestricted support to this event. And thank you very much for staying with us and really actively contributing to this discussion. So if you want to watch this content, it will be posted soon on PCR Online. Thank you very much.
Bye.
Thank you.